So now I would like to invite Dr. Jatinder Singh. So he'll be presenting on interpretation of fundus fluorescein angiography and indocyanine green angiography. Over to you, sir.
Thank you, Anand. Thank you, Purna. We heard two excellent talks, and I'm going to talk on something which is probably a dying art. What Buckle has seen in surgery is probably what FFA is facing in the era of OCTA. This talk is going to be very basic, and I hope the PGs and fellows they learn from something from it. So these are the first thing which I like to stress is fluorescein angiograph or angiogram is not a single image. It's a set of images starting from the early phase, the arterial phase, and going to the recirculation phase. So you have this picture. You are tempted to say that it is probably a normal angiogram. This is a late phase of a patient, of the same patient, where you can see a delayed arterial filling, and this patient, clinically, you can see that it is a central retinal artery occlusion. So never comment on a single picture. When there is a hazy view due to cataract or vitreous hemorrhage, you probably have to limit the expectations that you can derive. The interpretation of the angiogram has to be limited. So be wise then when there is significant cataract, that is you're not going to get enough information. Probably you can avoid an angiogram and defer the patient after cataract surgery or after the vitreous hemorrhage has been cleared. Sometimes you might be surprised in cases where clinical examination doesn't provide enough information. An angiogram will provide you absolute clear, pristine view of the posterior segment. So this is the case of asteroid hallosis where indirect ophthalmoscopy will not able to get clear picture because of the scattering of crystals. But this doesn't hamper the interpretation from an angiogram. Even before you start the dye injection, you can do something called as autofluorescence, put the barrier and exciter filters in, and you can pick up astrocytomas and optic nerve head drusen, which are associated with rod cone dystrophies or certain neurofibromatosis. So this patient presented with disc edema, went to pillar to post, got investigated including CSF tap, and actually it was just a simple investigation which could clinch the diagnosis of optic nerve head drusen. So fluorescence can be either hyper when there is increased hyperfluorescence from the image. From where you see a normal fluorescence, it can be either more or less. So when it is less, it is either because of blockage, that the fluorescence is there and it is not seen, or it is not there at all. If it is not there, it is a capillary filling defect. If it is blocked, it is because of an overlying lesion. And the size and the shape of the lesion that you see on clinical picture can be correlated with the angiogram, and it can give you a clue that it is a blocked fluorescence. In the first image, you see blocked of retinal and choroidal fluorescence. In the second, you can see some ground glass appearance in the temporal part, but you can see some amount of blocked fluorescence as well. So the color of the hyperfluorescence, how dark it is. If it is absolute jet black, it is probably because of blocked fluorescence. You might see some amount of ground glass haze because of some amount of choroidal fluorescence showing through. The last picture is of a CNVM. You can see the subretinal hemorrhage and the retinal vessels overlying it. So the location, the anterior posterior location of the lesion can be picked up on an angiogram just by interpreting the hyperfluorescence. So this is a case of ischemic maculopathy. You can see a capillary filling defect involving the macula in a diffuse manner. So hyperfluorescence and hypo are not exclusive of each other. Both can coexist, and very often they do. And this is a case of new vessel with intense leakage and the capillary dropouts. So most likely, most cases, you will see the new vessel formation at the posterior edge of the CNP areas, the capillary dropout areas. So coming to hyperfluorescence basically are of four types. We'll go one by one. This is transmitted hyperfluorescence. So you see the window defects and the pattern which is similar to what we call as the crescendo decrescendo. So as the dye increases in intensity, you will see the increase in the fluorescence, and it keeps dropping down and goes to the least in the late phases. These are the leakages. This is a typical smokestack leak seen in case of CSR. Initially, you would see a very small dot and it would rise from this. And this dye gradually starts pooling in the neurosensory detachment with the hyperfluorescence most intense at the periphery. This is another patient with a very similar kind of pooling, but in multiple cavities. and the leakage is coming from multiple pinpoint sources, this is the case of leakage. So the point to be stressed here is if you see multiple pinpoint leakages and single leakages, and single discrete leakages, the diagnosis can be different. This leakage is typically in the cystoid spaces within the macular area, the typical petaloid pattern seen in cases of CME. A classic CNVM would show a lacy network with some amount of block fluorescence if there is hemorrhage around, and this will become intense and the borders become fuzzy and enlarge. Occult CNVM also sometimes this might be misdiagnosed as a classic CNVM because it is well defined, but it is not lacy, and the fluorescence that is seen is like remaining the same. The borders are not becoming too blurred because of the surrounding subretinal hemorrhage. So this is a fibrovascular PED, the type 1 type of occult CNVM. Sometimes you might see intense leakage in the macular area, and on the clinical examination you don't see much, and OCT also doesn't show much of edema. So this is a case of a mactel where there is a abnormality in the capillaries around the foveal area which cause this leakage. The pooling is different. Pooling can happen in all anatomical spaces, most commonly in the neurosensory, under the neurosensory retina or under the RP. So if it is a very discrete, well-defined lesion and remains the same throughout, it is a pooling under the RP. And this hyperfluorescence is generally like completely filling that space. Whereas in neurosensory detachment, it is most intense at the periphery and there is a gradually declining hyperfluorescence towards the center. So this is not pooling because you can see the size of the lesion and the intensity of the lesion increases towards the later phases. This is a case of angioid streaks to help you differentiate what is leakage and staining. Here you see the lesion which is not the same as the hyperfluorescence that you see here. So this is a advancing edge of a CNVM related to angioid streaks, whereas this lesion in the lower picture shows you a scar and a corresponding hyperfluorescence to that. So the staining of the scar is usually well defined, and you can always go back and see clinically and correlate if it is corresponding to the same area. Neovascularization and collaterals can be easily differentiated. You can see the intense leakage that you see from the new vessels, whereas the collaterals will not leak as much. They might leak a little bit, but not as intense as the new vessels do. Abnormal vessels are also been classified under hyperfluorescence. I think it just if they leak or they are just a structure abnormality, so they do not actually describe a different pattern of hyperfluorescence. So each phase of the angiogram has its own significance. This is a choroidal fluorescence, slightly delayed in the elderly because of the reduced supply. If the choroidal fluorescence or the patchy fluorescence lasts for more than 5 seconds, it is considered as abnormal. Then we have the arterial phase. You pick up arterial AV transit time or the arm retina time in cases of occlusive diseases. The early phase and then the mid phase. Mid phase is the peak phase where we read all the capillary dropout areas. The late AV phases, we read the leakage. In the venous phase, we look for staining and pooling. There are times when we will be posed with this kind of picture, it's all messed up and the angiogram doesn't provide much clue, and ICG comes to the rescue. You can see polyps at the edge of the lesion, and this is the case of a polypoidal choroidal vasculopathy. So switching to ICGA, you can see the multifocal CSR here, but the pattern on the ICG is showing much more wider hyperfluorescent areas. And there are authors who believe that PDT guided ICG guided PDT treatment has better results as compared to treating just the focal lasers, focal points on fluorescein angiogram. This patient actually presented with a diagnosis of choroidal melanoma with a large elevation in the lower part of the retina with macula involved, and a simple test with ICG picked up a polyp. It was a case of PCV with intense subretinal bleed, hematoma, and we just did the focal laser for this leak and the patient recovered 6/6 vision. So PED can be serous or fibrovascular, and on FFA everything will look white and hyperfluorescent. But on ICG, we'll pick up serous PED as a hypofluorescent area, a hyperfluorescent lesion. And if there is hyperfluorescence within that lesion, it would be the fibrovascular component. So within the serous PED, sometimes you can have patchy hyperfluorescence on ICGA, which describes the or detects the fibrovascular component of the PED. You can also pick up hotspots and plaques. Hotspots typically are lesions which are less than 1 disc diameter in size, and they are supposed to be more active kind of CNVM lesions. The plaques, on the other hand, are wider lesions, more than 1 disc diameter size, and they represent a more quiescent or a quiet kind of a CNVM. The feeder vessels which feed the CNVM area can also be identified in the early phase by doing a video angiography on ICGA and immediately treat the patient, go back and do repeat angiography and see if the feeder vessel has been occluded. If not, it can be the treatment can be repeated again. So this video angiography with ICG gives us almost immediate feedback of our treatment. Coming to some uveitic entities, this is a patient who with mild myopia. You can see some hypofluorescent lesions on the ICGA. It helps us to differentiate a CNVM lesion which can be associated in myopia. This is actually a multifocal lesions with hyperfluorescence, not much of hyperfluorescent areas in the ICGA. And it was a case of a punctate inner choroidopathy. Lesions like Azure, you can see the trilaminar flow on the FFA, and it is much better differentiated or seen on the ICGA. The ICGA represents a larger area, and it actually identifies the entire lesion as compared to a fluorescein angiograph, which is affected because of the leakage. This is a patient with myopia. Again, you can see some lesions in the right eye around the disc, some amount of parapapillary atrophy. On the left eye angiogram, you can see fluorescein angiography not providing much information, but the lesion around the disc with some amount of satellite lesions spreading across the posterior pole gives a diagnosis of mutes, multiple evanescent white dot syndrome. So coming to the last image, this is the type 3 CNVM where Uni mentioned that Octa is still not providing enough information. You can see the intense leakage on fluorescein angiography, but on ICG you can see a clear RAP lesion. This is a stage 2 RAP, and it is well picked up on ICG, and direct focal laser or anti-VEGF therapy or combination therapy can be posed to these patients. So I would like to conclude by saying that fluorescein angiography is not a dying art. It should not be, at least I want to believe that, and I would encourage all the postgraduates to learn and understand by seeing more and more images. Thank you so much for your kind listening.